been no period for 12 months or more. And perimenopause then is the time from onset of menopause symptoms until cessation of menstruation. And for some women, this can last between 4 and 7 years. And blood tests can help your menopause diagnosis, but they're not definitive. So the types of menopause that can happen are spontaneous, surgical, and iatrogenic, which is a menopause caused by a treatment. So how does cancer treatments and menopause? So you can have surgical removal of the ovaries for your cancer. Some cancer therapies can affect the ability of the ovaries to produce eggs and hormones. Some patients may be already suffering from perimenopause before the commencement of cancer therapies. Chemotherapy and pelvic radiotherapy can also affect your ovaries, so they can also commence menopause. Your adjuvant therapies like your tamoxifen, your aromatase inhibitors, and some women would have commenced HRT before the cancer diagnosis, and that HRT was stopped then once they were diagnosed with cancer. So surgical menopause is any surgical surgery can affect ovarian function. Ovaries removed at surgery means estrogen can no longer be produced. And even hysterectomies with conservation of ovaries can sometimes affect ovarian function. So some surgeries like for rectal cancer and stuff can also affect ovarian function. Surgical menopause is permanent and irreversible. So radiotherapy, so how does radiotherapy affect your menopause? The radiotherapy effectively kills cancer cells, but given the pelvis near the ovaries, it can also affect them to lose their function. Radiotherapy can damage the ovaries, and this can be permanent and reversible, but younger women who get smaller doses of pelvic radiation may start to menstruate once the ovaries heal. And chemotherapy, so chemotherapy is designed to kill cancer cells, and this can be toxic to the ovaries. A proportion of women who are initially amenorrheic after treatment can experience recovery of ovarian function. It is more likely to be permanent the closer you are to the natural age of menopause, but it can't be predicted. So the adjuvant therapies, the aromatase inhibitors and the tamoxifen also affect menopause. Effectively, when you get tamoxifen and aromatase inhibitors, they actually put you into menopause. So nearly all adjuvant therapies cause side effects, and they cause you to have a lot of menopausal symptoms, especially the joint and muscle pain. And they can also impact on your vaginal health. So you have estrogen receptors in all parts of your body. So so the main symptom of menopause is usually the hot flushes. So about 70% of women suffer from hot flushes. Then there's lesser known symptoms like brittle nails. You're more prone to allergies, joint pain, especially with the tamoxifen, osteoporosis, because you lose your estrogen is used for your build up of bone, and when you lose your estrogen, your bones can be less strong, and you can have this itch and dry skin as well. So people describe it as insects crawling over their skin. So you can see from the picture everywhere you have these estrogen receptors, and everywhere when your estrogen fails, you can have symptoms. So evidence suggests that menopause caused by medical therapies may be more severe and long-lasting than physiological menopause. And following a cancer diagnosis, women may be also at increased risk of affective disorders such as depression and anxiety, and menopausal symptoms can exacerbate this risk. And younger age women at menopause have increased risk of cardiovascular disease, osteoporosis, and sexual dysfunction. So how is menopause diagnosed? So the symptoms mainly. So when you come to the clinic, we give you a check score, this green climatic score, and you can score it on whether the menopause symptoms bothers you a little bit, quite a bit, or they're quite bothersome. We also look at your menstrual history to see if you're still menstruating. And if you've gone through menopause because of surgical removal of the ovaries, no test needed as menopause is inevitable. We generally don't do blood tests, but if somebody is less than 45 years of age, and if there may be fluctuating levels that may make the diagnosis difficult, so that you might do a blood test then. But knowing that every woman's experience of menopause is unique to her, so there's no point in comparing your menopause journey with some other woman, because your journey is unique, and depending on when you started menstruating and what cancer diagnosis you have, your experience of menopause is unique to you. So how do we manage the menopause? So the main stay of management is lifestyle changes, hormone replacement therapy, prescribable treatments, vaginal treatments, and then complementary therapies. So helpful lifestyle changes are eating well, stopping smoking, doing your breast screening, your cervical screening, and protecting your bone and educating yourself. The more you know, the more you can be prepared for the menopause, and the more you can adapt your life to those changes. So eating well, so obviously eating well includes oily fishes, fruit and veg, whole grains, soya. So avoiding excessive red meat and sugars can improve your weight and hot flushes. Everybody in Ireland should take a supplement of vitamin D over the winter months. And a calcium-rich diet is very important for postmenopausal women, and about 1,000 milligrams a day is kind of the recommended dose. And this can be done by taking your cheeses, your yogurts, and if you aren't particularly fond of dairy products, you can also get your calcium from leafy green vegetables. So stopping smoking. There is nothing as important as stopping smoking, especially when you come to the age for menopausal symptoms, because smoking can intensify the symptoms of menopause. So smoking is a vasodilator. And if you can give up smoking at all, it'll be one of the main lifestyle changes that can really help. Nicotine affects the nervous system and estrogen levels and makes it harder to maintain good sleep patterns. And alcohol. So some women find that alcohol, particularly red wine, triggers hot flushes and night sweats. And also alcohol can affect your general mental health as well. So exercise. So regular exercise can help your sleep patterns, and it can help reduce your anxiety and low mood, and also keeps your weight down and keeps your bone healthy. But nobody's asking anybody to start running a marathon. It's just movement. So if you can even do a short walk as far as the front gate, and if you can extend that, but keeping movement and doing a weight bearing exercise. So going swimming or anything is very good for your cardiovascular exercise, but for your bone health, you must do weight bearing exercise. So that includes walking. So HRT then is the most effective treatment for the menopause, but this doesn't eliminate all symptoms in many cases. So even women that can safely take HRT, it does not alleviate all the symptoms. And your options and safety of use of HRT will really depend on the type of cancer you're being diagnosed. So most cancers that cannot take HRT are those with sex hormone cancers, sensitive cancers. So this little diagram shows you the cancers that can take HRT. So colorectal, vulval, vaginal cancers can have HRT if needed. Endometrial, some ovarian cancers, melanoma and lungs can have it under certain circumstances, and breast and some ovarian should probably not take HRT. So, but we're left with other choices then. So what are the non-hormonal medications that we have that help reduce the hot sweats and flushes? So we have SSRIs and SNRIs. So these are antidepressant medications that have shown to reduce the frequency and intensity of hot flushes and night sweats. So these can reduce your hot sweats and flushes by about 60%. But the only thing about them is they're really, really hard. Find patients are really reluctant to take them, because most of them will come in and say, I'm not depressed. But in fairness, we're not prescribing them for any depressive symptoms. We're prescribing them totally for the hot flushes and sweats. And we usually start off in a very low dose. So we also have gabapentin, and gabapentin is most commonly used for chronic and nerve pain, and sometimes used in epilepsy. And this medication also has the side effect of reducing hot flushes and night sweats. And taking a low dose, and we slowly build it up at night time, and it can also help with the sleep. So oxybutynin then is a drug that we normally use for an overactive bladder. And oxybutynin has been shown to reduce the severity and frequency of hot flushes, and it can be taken in a very low dose or as a patch. And then we have clonidine. Clonidine is one of the only drugs that is actually prescribed for, that's actually, I would say, registered for treatment of hot flushes and sweats. But actually, in fairness, the drug that we use least because the side effects. So side effects include dry mouth, drowsiness, and dizziness. And studies that involve clonidine are small, and the results are really, really mixed. So, but there's new options. There's a new drug on the market, and we're hoping to have it available in Ireland in the spring. And they're doing trials here at the moment, these Oasis 4 trials. But it's been in use in the US and Australia. And this one it's kind of a selective neurokinin 3 receptor. And it really is shown to produce the hot flush frequency and the severity and the quality. And the other part of the menopause then is this genitourinary symptom of menopause, or GSM. And this describes the group of menopausal symptoms, which include vaginal dryness, vaginal burning and irritation, and sexual symptoms such as lack of lubrication and dyspareunia. It also includes urinary symptoms such as urgency, frequent dysuria, and recurrent urinary tract infections. So some women complain of UTIs and in and out to the GPs looking for antibiotics, but sometimes it's actually the lack of estrogen in your vagina that's causing these symptoms. So you can kind of see here in the picture on the left is a very normal vagina wall, and it has these little rugae and this really thick vagina wall. This is premenopausal, and the picture to the right then is postmenopausal, where the wall has thinned and narrow and all those little rugae have gone. But we can help with this. So the causes of GSM are when the estrogen goes and your vagina becomes thinner and less stretchy. And the estrogen lowers the amount of normal vaginal fluid and changes the acid balance in your vagina. It can also shorten and narrow. And these can all make your vaginal tissue more delicate and more likely to be irritated. So the complications of GSM are vaginal atrophy can affect your quality of life and shape with your partner. You can have physical symptoms like pain, burning, itching, and leaking urine. And you can have emotional symptoms such as loss of interest in sex, intimacy, or loss of confidence. The treatments then, so local estrogen and vaginal moisturizers and lubricants. So the type of local estrogen comes in a number of varieties. So you can have a little pessary, which is comes like Vagifem and Vagirux, and it's a little pessary that's attached to a little applicator. And you could take a loading dose for the first 2 weeks and twice weekly after that. Invagis then is like a little suppository, and it doesn't require any applicator, and you pop it in into your vagina and for 3 weeks for a loading dose, and then twice weekly after that. And then we also have a cream and a gel, so Vestrin cream and Blissell gel. Blissell gel is a new product which also has a moisturizing property as well. So for some women who are on adjuvant therapy, they're not as inclined to prescribe vaginal estrogen. But there's very little research done on vaginal estrogen and adjuvant therapies. And most oncologists will prescribe, but not all of them. So it needs to be a discussion between your oncologist. So, but if you're on tamoxifen, it works differently from the aromatase inhibitor. It acts like estrogen in some tissue and blocks in others. For this reason, oncologists are more likely to consider vaginal estrogen when on tamoxifen compared to aromatase inhibitors. So vaginal moisturizers then, everybody can use vaginal moisturizers. It's like using moisturizing your face. So once you have menopausal symptoms, you should apply vaginal moisturizers every night, or at least 2 or 3 times in the week. So these vaginal moisturizers are specifically formulated for delicate vaginal tissues. So these brands include Replens, Regel, Yes, and Silk. And we also recommend that you use lubricants just before sex. These may be also water, silk, silicone, or oil base, and those brands also include Silk and Yes. So just then for your food and dietary supplements for the menopause. So there's lots of confusing message on what food may help during the menopause. If any of you ever have gone into any supermarkets, there's usually a wall-to-wall of menopause supplements. None of them have been researched and none of them have shown one to better than the others. So the most important thing is just a good balanced diet to maintain good health, the vitamin D, like I said earlier, and a diet with good calcium intake for bone protection. So some herbal products have been researched to see if they're menopausal benefit. So Black cohosh has been recommended as menopausal by WHO, but it interferes with tamoxifen. St. John's wort is on prescription only, but it has multiple drug interactions, and it's shown to be effective with low mood and menopausal flushing. Ginseng, better than placebo with dealing with hot flushes and cause postmenopausal bleeding, and can interact with warfarin and alcohol. So isoflavones as well, found in legumes, soybeans, chickpeas, and tofu. And the data is poor with this, and it's not recommended for breast cancer patients. So then we also have wild yam, red clover, dong quai, ginkgo, sage, maca, pollen extract, vitamin E, evening primrose. And there's no evidence on any research to show that these help with menopausal symptoms. But, you know, so then for your physiological and your psychological therapies. So in fairness, avoid heat triggers. So hot teas and coffees and spiced food and alcohol. So environmental adjustments. So if you're out and about, layer clothes. If you can have a small fan that you can leave on your desk. Lighter duvets, sometimes 2 single duvets. So that if you're sharing a bed, that you can pull off your duvet and you won't interfere with whoever you're sharing the bed with. And smoking cessation, like I said earlier, if you can give up smoking at all. Acupuncture. Acupuncture is one of the few therapies that has shown to have really good effect with your hot sweats and flushes, but really good favorable evidence to show this. Yoga, there's no evidence at the moment, but in fairness, it's a really good form of exercise. Hypnosis, no large studies, but what it can do is kind of change your perception of your symptoms. And cognitive behavior therapy. So cognitive behavior therapy is an accepted effective treatment to help women cope with menopausal. Cognitive behavior can't change the physical sensation for occurring, but with CBT can approach the situation differently. So cognitive behavior kind of looks at instead of having less favorable thoughts towards your hot flush, you have more favorable hot thoughts. So when you have your hot flush, you feel your hot flush coming on, instead of getting stressed and you feel your heart racing and making the hot flush worse, you try and change your approach to it, that you kind of go that you change your mindset, think that this hot flush will go in a minute, and if you just give myself a chance, it'll settle, and you don't increase your anxiety. So you can avail of cognitive behavior therapy by either having your GP refer you to Silver Cloud, which is an online self-direct digital platform for cognitive behavior, or you can use a self-directive workbook. Now we use a book recommended here in the clinic, is called Hot Sweats and Flushes. It's by Myra Hunter and Melanie Smith, and that kind of is a 4-week workbook that you can kind of work your way through. And then for further information, this is Go website is actually quite good. You log in, and it's very good for gynecological cancers. And the Women's Health Concern has really, really good leaflets on menopausal information. Your GP and the complex menopause services, which the service I work for is a GP referral service that you can refer from your GP if you have complex needs of the menopause. And that's it. Thank you.
Okay, Helena, thanks ever so much for that presentation. If you want, you can you can take the slides off and revert to this kind of ordinary view that says everything.